Hello and welcome to the Transplant Australia's fourth COVID webinar titled Living with a Transplant in a Changing COVID World. These webinars have been hugely popular for Transplant Australia over the past 12 months, and with our last session in November 21 with almost 400 participants and another over 400 participants registered for tonight. Tonight's session will be recorded and will be made available on the Transplant Australia website by tomorrow afternoon. As we are now 12 months out from the 2023 World Transplant Games being held in Perth, we look forward to celebrating the transplantation, donorship and the celebration of life, whilst also battling with living with COVID. Tonight's session will have some great insights and some absolutely fantastic speakers. So without further ado, please let me introduce Kate Wyburn, the President-elect of the TSANZ, to take us through our session tonight.
Thanks very much, Holly. Welcome everyone. I'd like to start by acknowledging the traditional custodians of the lands on which we meet, and to pay my respects to elders past, present, emerging, and with us, anyone with us today. So thank you so much for joining. It really is a great lineup of three speakers, and I'll introduce them each as we come. Certainly, the one thing that has been certain is that things have continually changed. So hopefully through this webinar, we'll continue to support each other and learn and share experiences. So please enter any questions that you have in the chat, and we'll try to get to them as we go, and we'll allow for questions at the end of each speaker as well. So our three speakers tonight are Professor Dominic Dwyer, Professor Germaine Wong, and Professor Steve Chadban. Professor Dominic Dwyer is a virologist and director of the Institute of Clinical Pathology and Research at Westmead. He was one of the Australian representatives on the WHO Delegation to Wuhan, so you don't get much closer to the epicentre. And he's going to talk to us tonight about the virus, why it mutates, and I guess how we can respond. So thanks very much, Dominic.
Thanks very much, Kate. I'll just get up my screen. And thank you very much for the honour to present to this group. I've had connections in the past with the Transplant Games and so on when swine flu was around a decade or so, or more than a decade ago now, and was mighty impressed with the organisation. So look, Kate and the team asked me to talk about where we're kind of up to with SARS-CoV-2, which of course is a virus that causes COVID-19, where we're up to and sort of what directions we might be heading. So there are a couple of things I'll cover just in the next 10 minutes or so, trying to give you an understanding of where we are now, try and sort of quickly answer the question of from where did the virus come, just a comment on one aspect of laboratory testing, talk about new virus variants, and then kind of crystal ball goes, if you like, is what's going to happen next. So look, these are the figures globally for COVID-19 infections, and there's well over 500 million cases that have been recorded, with about 6 million, more than 6 million deaths. And recently the WHO, the World Health Organization, in fact reported that this is a very significant underestimate, and that there's probably been about 15 million COVID-related deaths. And as you can see, like we know with other pandemics in the past, particularly with influenza, these sort of pandemics go in waves, and we all know this from even reading the local newspapers, but you have waves of disease as various populations are affected and new variants emerge. So these are the numbers in Australia. This is just, you know, we've had a different pattern in Australia with border closures for the first sort of year or so, but very significant outbreaks. A tiny little blip back in October, which was really the Delta outbreaks in Victoria and New South Wales, but very major activity in most of the country now due to the Omicron variant, and I'll talk a little bit more about that later on. We're now reporting about 7,500 deaths in Australia and about well over 6 million cases. And we know from some earlier work that this is probably a very significant underestimate of the cases, and it is probably at least 2 to 3 times that. Just to talk about the origins of the virus, this is some pictures that I took in the Wuhan market in Wuhan, and this is just a classic example of where outbreaks of disease can occur. You know, a crowded, dark marketplace, live animals stored, and living quarters of people adjacent, all a perfect recipe for an outbreak of something. And then, of course, if you put the market into the context of the city, then literally within a few hundred meters, you've got thousands of people living in high-rise, again, allowing disease to spread very quickly. Now, this is kind of a complicated slide, but really sums up the current knowledge about the pandemic and where it started from. So on the left-hand side, you've got the virus present in bats. We don't know where exactly these bats are, but probably in multiple places. Then you have sort of jumping across into various types of animals, either in the wild or indeed within the market if those animals are being sold. Then you get the virus circulating, and there are a couple of different strains, even right back in the very beginning of SARS-CoV-2. And then once it spreads within the market, given how crowded and busy they are, quickly gets spread into the local community, spread throughout the city. And then, of course, Wuhan is a very big and important transport hub for the rest of the world. And so off it goes. Now, the one thing I was going to move to in terms of laboratory testing was, I think we've all become very experienced with understanding what PCR and nucleic acid testing is, but we also talk a lot about RATs, or rapid antigen testing. And this has been very much part of the government strategy to sort of expand the access of testing. But, you know, there are pros and cons with RATs, and I think that's important to understand. So there are some problems with the RATs. They're inherently less sensitive than PCR or the nucleic acid testing, only about 70% or so sensitive. One of the particular problems is that a positive result is not entered into the hospital IT systems, and people have to self-report a positive result to the government. And we already know that there's very significant underreporting of positive RATs by people in the community. The other thing is that as time has gone on, we found a lot of them to have problems with false positive results. And in fact, the Food and Drug Administration in the US has now withdrawn many of these because of their poor performance. I mean, they are useful. The concept of them is useful, and there are some pros to using them. They're reasonably good if you're in the sort of peak of the infection, if you like. And of course, they're quick, which is great. And they have been useful in getting people back to work, getting schools open again, getting workplaces going, and allowing people to test themselves at home rather than coming in, for example, to the hospital environment sick to get a test. So pros and cons, but overall, we have to be pretty careful about how we interpret those. And I'm sure some of you may have questions about it. The other thing that I was going to talk about is just draw attention to the new viruses or the new variants of SARS-CoV-2 that are emerging. And these variants can appear in two ways. You can have what we call recombination, where basically two viruses in a cell in a person sort of merge and mix their genetic material, and then out pops a strain with a mixed genomic picture. In other words, bits and pieces of the RNA of both of those viruses. And there have been a number of these recorded, and you generally see them when you've got more than one virus circulating in the community. So for example, in Australia, we've described a couple that occurred when we had the Delta wave, and then in sort of December, January this year, Omicron BA1 came along, and the two of them were circulating, and a number of people were infected with both at the same time. and produce these recombinant viruses. The same when the BA2 lineage came along and displaced the Omicron BA1 lineage, and we got recombinant viruses. But in fact, what's a far more important way of new viruses emerging is just the gradual evolution of a variant, a virus, to produce something that's very slightly different. And this happens all the time. And there have been many, many thousands of new lineages of SARS-CoV-2 occurring. But the important thing is to understand which are the ones that mean something. And that's what we spend all our time working on. So look, you would have seen that list of names of new lineages: Wuhan, Alpha, Beta, Gamma. They've all gone, and they've been replaced by Delta, and even Delta in many parts of the world has now been replaced by Omicron. And most of these variants are coming from countries that may be underdone in terms of the availability of healthcare for COVID infection, treatments, vaccines, all of those sorts of things. And of course, with Omicron itself, we've now got essentially a truckload of these new variants. BA2 is the one that everybody reads about, but really in the last few weeks, we've already seen new ones come, BA4 and BA5. And kind of what this means yet for everybody, for vaccine effectiveness, for treatments and so on, is still being sorted out. This is just to give you a demonstration of what happened in New South Wales, and this is work we do here at Westmead, where we sort of geospatial model the variants as they appear. So on the upper left-hand side in December, in blue you had Delta, and then we started to see some Omicron in red. It originally all started up in Newcastle. You may remember a big outbreak in Newcastle. Then as we went on to January, basically Delta for the most part disappeared to be overtaken by BA2. And then of course we had BA1. Then we had BA2 appear. And you can see in February and March, it's a bit hard to see, but the orange coloured BA2 is now mostly displaced BA1 and become the dominant strain. And these are the sorts of infections we're seeing in hospital, seeing in intensive care units and so on. Now, one of the keys with these new variants is trying to work out two main things. Are they clinically important? In other words, do they cause more severe disease? And are they more transmissible or spreadable, if you like? And certainly with transmissibility, this kind of picture sums it up, so that we had the original Wuhan strain, these various other ones have come along, and the important new ones were more transmissible. And now with the sort of Omicron BA2, we're talking about a virus that's sort of 5 to 7 times more transmissible than the original Wuhan virus. And that's why we see these new transmissible variants displace the other ones. As I said, the key is understanding whether these are important or not from the clinical point of view. Most of them are not important, but the ones I've alluded to have been important. Some of them can be intrinsically resistant to some of the drugs, and I think Germaine is going to talk about that. There's certainly an issue with understanding where the vaccines may lose effectiveness. So most of the vaccines, of course, are designed on the original Wuhan strain. How good are these vaccines? How good are boosters against these new variants is really important. You can try and assess that stuff in the lab, but that doesn't necessarily translate into what happens in clinical practice. And that information, of course, takes longer, which makes it difficult. That feeds into, of course, a general anxiety about new viruses and what they might mean, and the media get, very excited about this sort of stuff. And I think make it actually difficult at the clinical and the patient level to understand, what's important. I think we will see, new waves of disease, for example, the BA4 and the BA5 that we're talking about, because it looks as though on preliminary work that it's more spreadable or transmissible. Whether it means anything in terms of disease severity, we don't know, but there's no evidence so far to show that it's going to be any worse than, say, BA2. And then to sort of get to the end now, what does this mean in the near future? And the near future for us in this audience is really what's going to happen this winter as we head into it. So I think there are a couple of important things here to be ready for, I guess, with winter. We are going to see these new variants, but we need to watch and see, and what they mean, and we are covered with vaccination as far as we can tell. But the important thing with winter is, will influenza come back? Will respiratory syncytial virus, which causes croup and bronchiolitis in kids, but also in people who are immunosuppressed or in aged care facilities and so on. These new viruses are going to be around. What do we need to do to protect ourselves from all of these? This is going to complicate hospital management. Coming to the hospital is already complicated because of COVID-19, but you know, how we manage our wards, our admissions, our dialysis, our presentations to the emergency department, all of this sort of stuff is hard to manage. And all one can say is, I'm sure we're going to be very, very busy this winter. The vaccination remains crucial, so the boosters are very important, but also the vaccination now for influenza, I think, is super important. And again, I certainly wouldn't be delaying getting your influenza vaccinations for this coming winter. We've seen very little flu over the last 2 years because the borders have been closed. Now we're starting to see, you know, quite a reasonable number coming in through our emergency departments. And there are some other vaccines as well, like for pneumococcus and so on. And I think the last point I'll make is that how we as a group and how you as a group of people approach what we call the non-pharmacologic intervention. So the sort of standard infection control things, you know, what mask wearing, for example, going shopping, sensible physical distancing, all of those things we can't turn off. Even though everyone would like to turn them off, I think we're faced with this coming winter with all of these viruses around, that we do need to be careful, and we do need to keep these so-called NPIs going, and something that I would strongly encourage you all to do. So look, I'll finish up there and thank you again for the intro. I'm very happy to answer any questions, Kate. Thank you.
Thanks very much, Dominic. A great travel through the evolution from the epicenter to now. There are a couple of great questions coming through. How is transmissibility of the virus measured?
Well, there's a couple of ways. Like with all of these things, it's like understanding how the vaccines work. You can do tests in the lab to try and work out how transmissible they are. So you can grow the virus up in the lab, look how it infects different cell lines, how quickly it does it, those sorts of things. And we do that, for example, at Westmead. You need a high-level security lab to do that sort of work. So that's a sort of lab-based one. The main one really is looking at the contacts of people who have these cases. So, for example, we have a process in New South Wales, and I'm sure it's in other states as well, where, for example, returning travellers to Australia, who of course are the people most likely to be carrying these new variants. Once you make the diagnosis, then you investigate the household, for example, to see how much spread has there been within that household. Then you look to see if there are outbreaks in certain types of facilities, like for example, wards in the hospital or nursing homes or prisons or any other kind of closed area, and look to see how quickly the virus spreads, not just to how many people it infects, but how short the period of time is between one infection and the next. So that's a broad way of doing it. Yeah.
Great, thanks. I've got a couple more questions before we move on to the next speaker. It's about the rat tests and I guess the pros and cons. The question is that they thought that the false negatives was the issue rather than the false positives. And can you confirm which is the worry?
Look, I think they're both a worry. Kate, the false negative rate, in other words, a number that it misses, you know, they're about 70 to 75% sensitive compared to a PCR or the molecular test, meaning that you're missing 30%. So 3 out of 10 or so. And there's also great variations, been shown in a number of places around the world, as to who does the test. So if you actually do these rapid antigen tests in a lab where the person is doing one after the other all the time, then their ability to read the assay result is much better. And that's different to doing it, someone doing it for the very first time in a home environment, for example. So 30% sensitivity, false negative rate. And we found, even though the companies claim a very high specificity, in other words, of false positives, in fact, we find it to be around 10%. So about 10% of the positives are actually not real positives. And so I think the take-home message is they're okay, but they're not great. And if there's any doubt about the significance of a result, be it positive or negative, you should go and get a confirmatory test.
Great, thank you so much. Probably in the interest of time, there's a few other questions, but I might move on and then we can come back to a panel discussion later on. So thank you so much, Dominic. Our next speaker is Professor Germaine Wong, the Director of Renal Medicine and Transplantation at Westmead Hospital, where there have been significant challenges, particularly at the end of last year and particularly related to the Omicron variant. And so she's going to describe for us, I guess, the changes of that clinical landscape and some of the management strategies. So thanks so much, Germaine.
Thank you, Kate, for the kind introduction. So thank you again to Transplant Australia for inviting me back to present some of our experiences at Western Sydney in terms of the COVID-19 infection in our transplant recipients, and also the treatment that we've been using since then. So what happened since last October? A lot of things have happened. So there is the end of the Delta outbreak, the emerging Omicron outbreak, with the new subvariant BA1 and the BA2, and a dark year have introduced the very third dose of COVID-19 vaccination. And then in a month later, they've also introduced the fourth dose. And then about 2 months later, they've changed their criteria for what we call the primary schedule from 2 doses of the COVID-19 vaccination to 3 doses for transplant recipients. And now we're eligible for the 5th dose. So a lot of things have happened. And more importantly, we also have some very important tools that we could use to fight against the infection. So this is an overview of the talk, a little bit about the Omicron wave and impact on our kidney patients, both on dialysis and also with transplant, our experiences, some of the things that we've done in terms of immunosuppression management and treatment, particularly with a focus on one type of monoclonal antibodies. I know Professor Chadban is going to talk a little bit more about antibodies and also new research. So this is our experience in Western Sydney. I believe the Omicron wave, and I can only sense it, started just after Christmas. This is what happened, and we had not been prepared for this massive surge because we really didn't have that experience during Delta. It was significant, but not as overwhelming as the Omicron wave. And you can see that this very steep going curve of the number of new patients being diagnosed with COVID-19 infection in the dialysis population. But thankfully, interestingly, as opposed to the Delta wave, the clinical manifestation and also the severity of our patients on dialysis with Omicron infection is not as severe. On the other hand, our transplant recipients, the clinical picture is very different. We may not have that greater incidence of patients diagnosed, transplant recipients diagnosed with COVID-19 infection, probably about 2 to 3 a day during the Christmas period to around mid-January. But we're seeing a lot of hospitalization and also really severe disease within the first 2 months of the Omicron wave. And I'd like to take this opportunity to thank the team, both the transplant team at Westmead as well as the infectious disease and the virology team who worked endlessly and most amazingly to serve our patients and collect these amazing data, which we're going to present to you today. This is data between Christmas Eve, I will say Boxing Day to the mid of January. We have had 41 transplant recipients, of which 39 are kidney transplant recipients and 2 are kidney pancreas transplant recipients. The mean age of our cohort were 52 years. Majority were male. Most of our patients, thankfully, were double vaccinated. Approximately half were also triple vaccinated. And interestingly, these are the presenting symptoms. But most of our patients had cough, myalgia, and sore throat and fever, which is quite typical in the general population. But having said that, they also present, some of those patients presented with gastrointestinal complications such as diarrhea, nausea, vomiting, and also acute kidney injury where the kidney function deteriorated within a very short period of time. We have over 50% of our patients being hospitalized, of which about 20% received intensive care treatment. And these are really severe disease that they require, respiratory support and also other types of intervention. Unfortunately, 3% of our patients passed away within that 30 days since diagnosis. We were very lucky to actually have access to the new monoclonal antibodies at the time, which is the Tropomab. And for those that are eligible for Tropomab, we gave them this specific medication. And the eligibility criteria at the time were they have to be less than 5 days of onset of symptoms, they have to be mild symptoms, and approximately 65% of our patients received and were eligible for Tropomab. And thankfully, of those that received the Tropomab, about 63% remained as outpatient and had very, very mild symptoms. And what have we done in terms of the management? So we typically reduce the antimetabolites, and commonly used in Australia are the mycophenolate and the azathioprine. And if they were unwell, really unwell, we stopped them completely. At the same time, we also stopped or reduced the tacrolimus and cyclosporin. And if they were admitted to ICU or high-level care, we stopped them completely at the same time. And to prevent the risk of rejection, we tentatively increased the prednisolone doses. In addition to the immunosuppression reduction therapy and changes that we've done, we've also given them special medications. And some of these medications are also being used for the treatment in rheumatoid arthritis and other autoimmune diseases, and also, interestingly, for the treatment of antibody-mediated rejection in transplant patients. The other infection-specific medications that we've given them were the antivirals, such as the remdesivir, and antibiotics if they have superimposed infection. Dexamethasone, which is really high-dose steroids, were also used to dampen that inflammation. What we found was that the prone position was actually quite helpful if they are really hypoxic. And unfortunately, a few of our patients required dialysis for their acute kidney injury and also needing the additional form of supportive therapy called ECMO therapy to support the lung. I just want to briefly touch on vaccination and antibody responses, which I believe which is of interest to our patients. We're very fortunate that as I said previously, 98% of the population vaccinated, are double vaccinated. And of these population, about 44% had an antibody response to the spike protein, which means that you have a response to the vaccination. of those that had the triple vaccination, about 50% also had that antibody response. So there's additional incremental benefit of actually having that triple vaccination. We had collected a lot of data for our patients, and what we did was we put them into a model, like a machine learning model, where we looked at specific factors that predict really bad outcomes, and that means hospitalization. And none of them were actually significant, apart from the use of monoclonal antibodies. And at the time, we used Tropomab. And I fully understand that currently Tropomab was not being recommended in the Australian COVID-19 treatment schedule, partly because of the concerns about efficacy. And at this stage, I'd like to talk about the resistance to Tropomab, and this is work done by our Westmead team, the infectious disease and the virologist team, and led by Dominic, and also Pathology, in terms of looking at the resistance. So what they did was they looked at 100 consecutive patients at Western Sydney who actually had Tropomab. And of these patients, 8 of these had persistently positive PCR testing. And they sequenced those patients and found that they developed a specific mutation against this special protein for which the monoclonal antibodies unfortunately didn't work specifically. And of these 4 patients, 2 of them were transplant recipients. So the take-home message is, what is next? I don't think this endemic, I would say, it's going to end. The infection, as Professor Dwyer pointed out, is going to last, and we need to consider boosters, but some questions do remain. What type of boosters? How frequent do we boost our patients? What about patients that do not respond to the vaccines? The duration of that response to the vaccines, how long do they last? What happened to patients that, again, that didn't respond at all with multiple boosting? What can we do? What can we do with the immunosuppression? So I would like to take this opportunity to tell you a little bit about our trial. This is what we call the Boost IC trial. It is a randomized control trial looking at patients who had a solid organ transplant, people with HIV, and people with hematological malignancy. And what involves are multiple boosting strategies, looking at different types of vaccines and boosting up to 6 doses of the COVID-19 vaccination. And on that note, I'd like to thank everybody who has been involved in the design of this study. And again, it is a national collaboration. So again, thank you to all. I'm happy for questions.
Thanks so much, Germaine. There's quite a few questions that have popped up, so we might run through some of these now. The first question is the vaccine for Omicron variant different to the COVID-19 vaccine? I think that's just one to clear up for people.
And correct me if I'm wrong, Professor Dwyer, they are exactly the same.
Good. I guess there's lots of different vaccines, but they're all just against the one COVID.
Yes, that's right. And I think that we're heading towards trials of vaccines that are being made with some of the new variants, but we're way off at the moment.
Great, thanks. Again, going back to clinical, there's a question that says, is there any data relating, I think they're saying, to the general health of transplant recipients with severe COVID impact? So I suppose a correlation there.
Yeah, I mean, long COVID, it's one of the things that we're really keen to look at in the future. And we are seeing a lot of fatigue in our patients, and also very small, I would say, about 5% of patients who had been infected with really severe disease had chronic lung damage, and those population are it's a critical important problem that we really want to address. And yeah, absolutely. And patients that actually have recovered from acute kidney injury, and then also that specific group of patients that we also want to follow them up in the longer term.
Yeah, fabulous, thank you. You mentioned reducing mycophenolate in the context of people with COVID. The question here is, would reducing mycophenolate for a short window after vaccination improve response?
Ooh, that's an excellent question, and it's one of the things that we want to address in one of the current trials that we want to look at specifically. Does having a short period of reduction in your immunosuppression, be that the antimetabolites or the CNIs, does it help in terms of the antibody response? But more importantly, it's not just antibody responses, but also the other type of immune response called a T cell response, which Professor Chadban is going to talk about a little later. Yeah.
Great, thank you. Just again, another clinical question, which I think you've largely covered, but given the current situation, the question is, if patients recovered, how was their kidney function affected?
Excellent question. And of those, I think I can't exactly remember the number, about 13 to 15% of a patient who had an acute kidney injury that required dialysis intermittently, they had a good kidney function after 60 days post-COVID infection. These are the patients that have survived. As I said, there are 2 patients, unfortunately, have passed away during that very short period of time between Christmas, I should say, no, Boxing Day, and mid-January. Yes.
Great, thank you. And just another question relating to Tropomab. The question is Tropomab still given to kidney patients?
The answer is no, currently. We're not, it's not currently in the formulation, I believe. Certainly not at Westmead.
And I think that probably relates to the fact of its efficacy, would you say? So it's not that we sort of can't get it, but we think they're better treatment, perhaps.
Correct. I think there are 2 oral treatments, and maybe Professor Dwyer can elaborate a little bit more in terms of the resistance that his team have been seeing recently, which is why they've been taken off the market, I would say.
Yeah, I think there's 2 points with drug resistance. You can have viruses that become resistant on treatment, and certainly that's what you presented with Tropomab, and particularly with some of the older strains like Delta and so on. Or you can have resistance that is intrinsically present in that particular strain. So, for example, the BA2 Omicron strain is intrinsically not very sensitive to Tropomab. And now that that's become the dominant strain, then, I think people are no longer using it. I mean, you can argue a little bit about whether the clinical effect is still present to some degree, but I think most people have gone away from using Tropomab because BA2 is everywhere, and gone to one of the other drugs. Yeah.
Thank you. There are quite a few other questions that I might come back to, but one question, I guess, for the non-kidney people, because we're a bit kidney focused, is there a different approach for liver transplant as opposed to kidney recipients? And there's also some heart recipients online too.
Kate, I'm so sorry. I really cannot answer that question because I'm a kidney and kidney pancreas transplant physician. Maybe you might be a better person to answer that with your experience in PA.
Yeah, I mean, I think our liver physicians probably have a very, very similar approach. And I would assume the heart as well. And we haven't heard that they've really had a different approach to what you outlined and to the treatments that are available. Again, Steve, go.
Hey,
I'll introduce you properly.
I was just going to chime in there because we have regular meetings with lots of the heart, lung, liver people from around the country. And I think the one thing to say is that there are subtly different treatments right around Australia because of people's different experiences. In general, the approaches to all of the organ transplants are pretty similar. We were really worried about people with lung transplants because the virus attacks your lungs when that's the transplanted organ. We were very worried. But I think a really bright spot on our horizon is that when you look at the outcomes from COVID across Australia among all of our transplant recipients, our survival rates are at least as good or better than anywhere else in the world. So I think that whoever's looking after you out there, you're probably in pretty good hands.
Absolutely. And now, for someone who needs little introduction, we might move to your talk, Steve. So Professor Steve Chadban is Chair of the Clinical Advisory Board to the Australian Organ and Tissue Authority, a clinician researcher in the field of kidney transplantation, and has done some great recent studies into ring immunity and antibody responses to COVID, and he'll take us through some of that. So thank you so much, Steve.
Hey, thanks very much, Kate. Look, I've got a kind of complicated area looking at how your body's immune system responds to COVID vaccines and COVID viruses. I'm going to focus on antibodies because I think that the response that we see in antibodies, in most of the data we've been able to see, does predict the response from T cells and other aspects of your immune system. So with that in mind, I'm going to try and walk you through antibodies to COVID-19 from the perspective of a transplant recipient. If I can figure out how to advance my slides, there we go. What are antibodies? Well, I think the most important thing about them is that they kill the virus that causes COVID. The more antibodies against COVID that you have in your system when you come upon that virus, the faster it will remove the virus from your system, the shorter the illness that you'll have, the faster you'll recover, and the less likely you are to transmit that virus to other people. So as a general term, we like you to have plenty of antibodies against COVID-19 in your system. Where do they come from? Well, they come from one of two places. You can either build your own antibodies, or you can get antibodies from somewhere else. We prefer those that you build yourself, and they are built by your body when you're vaccinated or when you get an infection with COVID. We'd prefer that you're vaccinated rather than have to get infected to do this. In either case, little bits of the virus or the vaccine are taken up by B cells, which triggers them to make the antibodies that protect you. We know that some people don't make enough antibodies, and for those people, we have the option of taking antibodies that are built essentially in a factory, and Germaine has mentioned two of those, being Tropomab that we have used to treat COVID in the past, or Evusheld, an antibody that's coming onto the market that we're going to use to protect people who have low levels of antibody after vaccine. There's a fourth alternative. In some international research, we've seen people who've actually known to have antibodies in their system provide blood from which antibodies are removed and are actually given to people with COVID to try and boost their immunity. In Australia, that's not been our practice because it's not very successful. So for this talk, we like vaccine-induced antibodies. And the reason that they're important is, I think, best demonstrated by this sort of data. In 2020, as Professor Dwyer showed, we had the outbreak of COVID. At that stage, we had no antibodies around. Nobody had seen the virus before to develop their own antibodies. We didn't have a vaccine. And during that year, if we look around the whole world, we saw that 25 of every 100 transplant recipients that were infected with COVID died from the virus. A terrible outcome, and had us all extremely worried. If we fast forward to 2022, when we still see very active COVID around the world and in Australia, there's a huge difference. We've seen only 3 deaths per 100 infections in this country. Probably one of the reasons is that the vast majority of our transplant recipients do have antibodies, mostly through vaccination, some who've been treated with antibodies, such as Germaine's and our patients, where we've given Tropomab, and others because they've been infected with the virus and developed their own antibodies that way. The data I've shown you here is for kidney transplant recipients, but it's highly likely that the same applies for liver, lung, heart, and pancreas transplant recipients. So what happens to your antibody levels when you are vaccinated? And this is a cartoon. What's important here is that the black dots represent doses of vaccine. The green area on the graph is where you've got very little and effectively no antibody, and that's where we start off. As you jump into the blue zone, you've got a modest level of antibody that we think provides you with a bit of protection against infection, we think. Once you jump into the yellow level and you've got much more antibody, we feel quite comfortable that you've got sufficient antibody there that will probably protect you if you get the virus. It won't stop you getting it, but it should enable your body to control it and clear it quite rapidly to reduce the chance of you getting seriously ill and to reduce the chance of you transmitting it to others. So if we think about a typical transplant recipient who starts with no immunity, gets a single dose, we get tiny levels of antibody produced, but the immune system's primed so that when you get a second dose of vaccine, you boost up into the modest level. This was shown by Germaine's data, whereby a moderate number of people who'd had 2 doses had some antibody that we could detect. We then give a third dose, and hopefully a lot of people boost up into the protected yellow area. What we do know, however, is that you don't remain there forever. Over time, the levels of antibody drop, they wear out. In medical terms, we call that waning. And at that stage, you need to get a 4th vaccine or a booster to kick you back up into the yellow area where you're well protected. Now, that's what happens for the majority of transplant recipients. But unfortunately, 20 to 40% of transplant recipients follow the red curve, whereby the first dose doesn't do very much at all. The second dose gets a little blip of antibody, but it goes away quickly. And then even third and fourth doses don't generate protective levels of antibody. And this is a real problem going forward. We, as clinicians, are grappling with what's best to do in that scenario. It's an area of intense research. So just to think about what all this means in terms of protecting kidney recipients and all solid organ transplant recipients against COVID, what can we do now? Firstly, we encourage you to get vaccinated. As Germaine stated, 3 shots followed by boosters as advised by your doctor and as advised by ATAGI represents your best way to protect from COVID. As Kate mentioned, ring vaccination works. This is a concept where if you live with other people, it pays great dividends to make sure that they're vaccinated, because if they are, they're less likely to catch COVID. If they do, they're more likely to clear it from their system very quickly and far less likely to transmit it to you. In working with Toby Coates in South Australia and their great team there, we showed by comparing transplant recipients with someone of the same age from their own home, the transplant recipient's immune response was much less than their non-transplant person they lived with. And our data would suggest that that person would be very well protected and much less likely to give the virus to the transplant recipient. The third thing we do to reduce your chances of exposure is going back very much to the non-pharmacological measures. Please do wear a mask when you're out in a crowded area. Avoid indoor crowds, wash your hands frequently, and avoid sick people as well. All of these smart things pay real dividends. Fourthly, if you do develop symptoms, please do get tested and contact your transplant team. We have 2 key things we can offer you. Firstly, we can monitor your symptoms and advise you when to get to hospital and how to get to hospital if that need arises. And secondly, we can often offer additional treatments, as Germaine alluded to earlier. We have some oral antiviral drugs and some antiviral drugs we administer in the vein at hospital, both of which are quite effective in transplant patients. So please do contact your team and do it soon, because the earlier you let us know that you're infected, the better the chance that we can do something about it. What might we be able to do in the future, and where are we heading with this? Firstly, in the future, we might be able to measure your antibody response to figure out whether you are following the black line or the red line. If your response is poor, then we can either offer further doses of vaccine or alternately give you a manufactured antibody, and here Evusheld is coming into play. On the flip side, if we check your response and it's good, we would strongly encourage you to keep up the regular boosters, continue to wash your hands and take care and try and avoid COVID. And we can then have some confidence that you're protected as well as you can be. In the background, please be reassured that we need more research and we're doing it. Not only us, but the government through ATAGI and also our COVID transplant workforce continue to review all of the data globally on a very regular basis. And we're actually talking and communicating productively. Below is a little paragraph from a letter that the chairs of ATAGI wrote to us at the COVID transplant task force only last week, where they, as they state, they would like to take this opportunity to assure you that ATAGI continues to monitor the evidence relating to immunocompromised populations, i.e. transplant groups, including consideration of the duration of COVID-19 vaccine protection and the risks from variants of concern. And I think that sort of ongoing regular dialogue between us and the authorities is really healthy to get maximum access to the best care for you. In closing, I think there is some optimism. This is the graph that Dominic Dwyer showed you in the first talk that shows the waves of COVID and the number of patients infected this year. But as you can see, the grey line shows that the risk of dying from COVID, despite those huge numbers, is diminishing. We've clearly seen that in our transplant populations too. So despite a very tough start to 2022, I think things are improving. I'd like to acknowledge my team at RPA and U Sydney, both Kate and Germaine. We all work closely together. I'd like to thank particularly the Organ and Tissue Authority and the COVID Task Force teams who do meet at least every month and have done so throughout the pandemic to try and guide our response to help all of us get through this. ANZ data provides fantastic data about the number of infections we're seeing in our kidney transplant recipients and their outcomes. And then finally, our team that we work with, the collaboration between TSANZ and Transplant Australia is really key, I think, in getting us all on the same page and getting the best outcome for you guys. Kate, I'd like to close there, and I'm also happy to take questions. Thanks very much.
Fabulous. Thank you so much, Steve. There's quite a few questions that are coming through about where do I or how do I get tested, or I've been advised that I shouldn't get tested, or what does it really mean, and how do I really know if I have had a response? Are you able to address some of those issues?
I think the first thing, antibodies aren't the be-all and end-all, and I showed you some concepts, but I can't say that if you have value X, you're 100% protected, and if it's half of X, you're only half of protected. The relationships really aren't that clear. I think the concept that we are all working on is the greater the levels of immunity you have, the higher the chance that you're well protected against COVID, number one. Number two, as Germaine mentioned earlier, there's more than one part of the immune response, and probably the T cell response is just as important as the antibody response. What we have seen in some of the research we've done is that by and large, the two go hand in hand together. So we think that measuring the antibody response is probably a pretty good marker of what's going on. But my final point would be that the immune system is only one part of your defense against COVID. There is your general health. What is your underlying organ function? How good is your kidney function if you're a kidney transplant? So it's a little bit like this, how do you reduce deaths from car accidents analogy? If you stop speeding, you probably reduce the death rate a whole lot. But there are other factors like drunk driving and talking on the telephone that also add that we're less able to measure. And I think that's probably the best way to think about antibodies.
Fabulous, thanks, Steve. And just in terms of access to the tests, people are wondering about that.
Wow, I think we've got an audience of 250 from around Australia, and everybody will have different access. Our hospital has just provided the availability for us to look at our inpatients in terms of measuring a couple of the antibodies, one that tells you whether you've been infected, another that tells you whether you've been vaccinated and how good that is. But I think everybody's got a different test and a different measure all across the country in private and public. We would love to work towards one uniform system, and we're working on it, but we're not there.
Thanks, Steve. And just a question on ring vaccination regarding the family members. Are they eligible for an extra sort of a second booster dose if they don't meet other criteria? Can you super boost your ring?
Again, just like we don't know exactly what a specific level of antibody means, we don't know that a super boost provides extra protection. I think that the ATAGI, the Australian Government Advisory Service on Vaccination, looks at the whole population and provides best advice according to your health status. So I think that so long as we get your household members to follow the ATAGI advice for them, that is the right thing to do, and that should get you good ring vaccination protection.
Fabulous, thanks. And then just two more questions for yourself, Steve. What's the best interval after which I guess you've either had the virus or the vaccine to check the antibodies? And just related to those boosters, does that ever conflict with your immunosuppression medication?
Yeah, two complicated questions. Most of the studies that have looked at antibody responses to vaccination or following infection have measured antibodies somewhere between 2 weeks and 4 or 5 weeks after the dose. That makes sense when we look at how B cells work, but to be honest with you, I don't think we have a precise example on that. I think around about a month, give or take, is probably a good place to measure. That was the first question. The second question, Kate, I've lost in my mind.
The second question was whether or not there's any interaction between immunosuppression and all these boosters we're asking.
Almost certainly, and Germaine alluded to her trial where she's going to look at modifying the dose of immunosuppression. Now, a little bit of a sneak information is that we had done what we call a pilot trial with fairly small numbers, looking to see whether we could take away one of the drugs, the mycophenolate in particular, and swap it to another, which we'd associated with better immune responses. When we switched it out and vaccinated 4 weeks after that switch, it doesn't seem that that's long enough to let your body's immune system to recover to get a better antibody response. We haven't looked at the T cell responses yet, and we think that it just might help the T cell responses a bit. I would say there's a whole lot more research required, and I certainly would not advise anybody to lower their own immune suppression to try and boost responses. Please do talk to your transplant physician, because I'll bet they're up on all the latest advice.
Thanks. And I guess the flip side to that is there's no adverse interaction, though, if you have the vaccine, that will impair or affect your immunosuppression, I think.
Not from my perspective. We should throw to Professor Dwyer about that as the virologist, but we see no interactions whatsoever.
Yeah, no, I agree entirely, Steve. Yeah.
I might throw a few more questions your way, Dominic. How do transplant patients travel safely internationally at present? Or have you got any advice for that?
Well, look, I'm not directly experienced with travel for transplant recipients and you know, their medications and access and so on. Certainly with my own clinical practice with immunosuppressed patients, for example, with HIV, then, and indeed for anybody, to be honest, is that I think we're at the stage at the moment where you need to make some sort of risk assessment of where you're going. In other words, first of all, making sure that you satisfied your own country's requirements and access to vaccination in particular, and the appropriate number of boosters and so on, that you have an understanding of the country you're going to and what their requirements might be. Now, these are changing all the time. I think today New Zealand finally dropped all of their travel requirements for COVID. So you need to know what the country you're going to has in terms of requirements. And I think, to be honest, some sort of assessment of where you're going in terms of, are they in the midst of an Omicron or other variant surge? So in many parts of the world, or in some parts of the world, they're well and truly in the midst of big surges. For example, going to New York might be risky at the moment because of what's going on there, but other places might be perfectly okay. So in other words, I think you make some sort of risk assessment yourself of where you're going and what you're wanting to do and so on. Clearly, if you have underlying medical conditions, you need to discuss that very importantly with your transplant physician. or surgeon to get the right advice. And I think also if you're going to perhaps more exotic places, the sort of travellers' medical vaccination centres are often provide quite good advice about both drugs to prevent things like malaria and so on, or indeed vaccination. But again, I'd be doing that in conjunction with your own specialist.
Steve.
Kate, 3 quick things that I think are key take-homes about that for our patients. Number one, some people that have had an infection have said to me, well, I'm fine to go overseas now. A little caution is that not every infection protects you completely against the different variants that may be active elsewhere in the world. So don't go away thinking you're 100% protected. Number 2, anyone can get COVID whilst they're overseas. If you do, it will likely delay your return to Australia. So like with all travel, always take twice as much immunosuppression as you need, just in case you get stuck somewhere. The last thing we want you doing is running out of your immunosuppression drugs. And the third one I'm often asked is, can I buy some molnupiravir or some sort of anti-COVID viral drug to take with me traveling? I think that's really difficult to access, and I think you're far better off to seek expert advice in the country you're in should you become ill, or alternately, ring back to Australia and talk to your specialist if that occurs.
Thanks very much, Steve. Just in line with other antivirals, there's a comment that we've sort of discussed Tropomab, although that's no longer sort of been actively used. And perhaps Germaine, I wonder if you can comment on some of the other options that are being used now, and specifically people have also asked about remdesivir.
Thanks so much, Kate. So there are 2 currently available oral medication, which is, Steve has alluded to, the molnupiravir, and also the other one is the Paxlovid. From my perspective, obviously, from the transplant recipient perspective, we would not use the Paxlovid because of the interactions with the tacrolimus and also the cyclosporin. So the molnupiravir is the one that we've been using for our transplant recipients. So, and that's been registered and allowed to use. The other monoclonal antibody that, again, Steve has alluded to, is the Uvashel. There is a limited stockpile currently within Australia, so it's very limited in that sense. But I believe ATAGI and also the Commonwealth are actively seeking access to these specific monoclonal antibodies, but that's only for prevention, not for treatment. Remdesivir, my experience is that we have been giving it to all our patients and dose adjusting according to the kidney function, particularly even for our our dialysis patients as well. So in terms of efficacy, look, difficult to know. In a clinical settings, those that receive them, they're actually well enough to receive them, and they did okay in the end. As Steve pointed out, we really need more research in this space, and this virus isn't going to go away, and we're going to monitor that over time.
Thanks so much, Germaine. I've got about 30 more questions and about -5 minutes. So what we might do is, I think, address all those questions offline, and we'll provide answers to Transplant Australia. And also, I suppose, if you have additional questions, please feel free to send them through. One question was in regard to how to get involved in the Boost trial, and we'll provide a link to Transplant Australia for their website. But I might wrap up now, and I just wanted to thank all the attendees. I guess that's a testament to your diligence and intelligence, you know, the high level of engagement that we've come to expect. And I think that's probably one of the reasons why we have seen a lot of reasonably good outcomes, because of the care and diligence you take. I also want to thank all our speakers for their clear, their insightful talks, and for sharing their experience. So hopefully we've answered some of your questions. We'll follow up with some more, and I'll just hand back to Holly. So thank you very much, everyone.
Thanks, Kate, and thank you to our fantastic and amazingly high caliber of professional speakers that we had today. The information was so current but also prevalent to, you know, as transplant recipients look to how they live in this world, and excitingly how we look forward to things like the World Transplant Games coming up in April next year over in Perth. So thank you again, everyone, for coming along. And as we mentioned at the start, this session has been recorded and will be available on the Transplant Australia website by tomorrow afternoon, as will any information around the World Games, which registrations are currently open. So you can check out the Transplant Australia website, or you can go make sure your membership is up to your Transplant Australia free membership is up to date, and you can have updates emailed directly to you. Thank you again for your attending tonight, and we look forward to seeing you at our next webinar. Have a great evening.